I think the big part of the society, we're having these sessions now that everyone registers their trials, participates, so all that data is available to move the field forward. As you know, you cannot publish anymore without having an NCT number for most of the stuff, most of your applications in the major journals. My disclosures, I do work with Philips and Nanospectra. I'm the national PI for the study. We recently published our paper in PNAS in September, looking at the feasibility and safety profile of the gold nanoshell directed ablations. Our primary endpoint at 90 days, there's a 78% success rate in the intention to ablate the zone, and at 12 months, it's 72% negative biopsies in those areas. So let me tell you a little bit more about the inclusion criteria and how things are changing. We accrued for our first 45 patients, and now we're in the extension study, which we changed the criteria to maybe include the low volume, low risk Gleason 6 disease, because it is difficult to find a specifically only intermediate risk or low risk area to treat. And majority of the patients in the trial have clinically significant prostate cancer, Gleason 7. I was criticized in the beginning for having a biopsy too early by, of course, Dr. Emberton. He said, you haven't given enough time for an immunological response to maybe kill off any few cells or let it die. The reason we did it early in our trial was we had no idea how the technology was really going to work with a focal ablation. So we needed to be able to get data back quickly and then alter our technique. And we went through a lot of alterations. Well, if you haven't heard about the nanoparticles, how do they work? Typical laser energy creates heat and ablate a specific zone. The difference is that you can have these nanoshells present within tumors, and then the infrared light that we use is specific to the particles. So the particles then heat up and then kill the tissue. And this is achieved because the nanoparticles are tuned to a specific wavelength to absorb the light energy to heat the tissue. And if you look on the screen, these are the nanoshells. This is blood and this is water. As you can imagine, we're made of a lot of blood and a lot of water. And if you can pass energy through that and only heat the specific areas, you can get a lesion-specific ablation. And using subablative powers, people that do lit, you're looking at 15 watts. We're working in the 5 to 6 watt range for energy. On treatment day 1, patients are infused with these nanoshells, an IV in the office. It's allowed to circulate for 24 hours. The leaky endothelial cells or vesicles could transport these nanoshells into tumors where they preferentially accumulate. People always ask, what if it goes somewhere else? They're completely inert devices. This is not a drug. Therefore, you have to excite them with a specific wavelength, and a photon only goes about 5 millimeters from the source of the energy, so it is very specific. Example of how we did this. Initially, I was doing work with Philips. The company came to me and asked, is there a way we can actually target areas within the prostate? And I said, I have this great idea. I have a pre-release platform we've been working on, and this can help us. And this is where the foundation for fusion really grows into focal therapy, because now we biopsy it, we can treat it, and we can use these technologies to record the digital information space to look at follow-up. This is an example of using the Euronav. With it, this is just a field generator. This can also go on the side if it's in the way. We use it for cryo. We just put it on the side so you can get access to the penis. These are laser trocars that are placed into the lesion all at once. The reason we put them all in at the same time is because the prostate rolls. And when you have a very specific lesion-directed ablation, if you have some movement of the prostate, you could have a skip lesion and have a failure for your treatment. Example, at 48 hours, we do get an MRI to determine if there's adequate ablation. Top row is ablation. The bottom row, you can see the first 2 sequences, almost completely useless. Now, they're useless because there's edema, non-specific changes. But when you look at the DCE, you have it in areas of lack of enhancement. And this is the thing, if you use a biparametric platform to screen your patients on, and you're not getting DCEs and focal therapy, how are you going to know if anything changed? And that is difficult. At 3 months, you can see there's contraction of the ablation zones and lack of enhancement. And this is what we're working towards. Now at 6 months, we'll get imaging and biopsies, And the 3 and 12-month biopsy results are here. The group is bigger than this paper, and I'm going to show you the overall trials data. It's at 3 sites. But the technology works with the idea that if Auroshells or the nanoparticles are present, you're able to generate heat. On the other side, if there's no particles, there is no heat generated. This is my first case. This is his left apex lesion. This is post-op. You can see here is a trocar that went through. It's 2 millimeters from the urethra. It's able, this energy went this way, didn't have any adequate uptake of nanoshells, so the urethra was untouched in this case. But you can see we have an adequate ablation zone on the other side. Michigan, Mount Sinai, where I used to work, in UT Health with Dr. Canfield, and Michigan's Dr. George, these are our overall results for 45 patients in our phase 1/2 part of the study, which is 78% success rate. At 12 months, 72% of the sites have a negative biopsy in the ablation zone. And I want to say thank you for your time. I'm watching the clock. I love that there's a timer there, Dr. Katz.
Thank you very much, Art.